Good
Dr.
evening.
Anish has joined, sir. Dr. Anish is heading critical care at Max Gurgaon. And Dr. Angel is neurologist at CMC Vellore, sir.
Good evening,
Yeah,
sir.
yeah, good evening. So we are on the right time ना?
Yes, sir.
Let me change the logo. अभी तक चालू नहीं किया ना?
Nice, sir. Another minute or two.
Sir, we are live.
मुझे एसएनसीसी का बैकग्राउंड भेज देना.
धवल
You have the एसएनसीसी background?
धवल मैसेज में डाल दो यहीं पे.
I will change it ना. So let the all faculty complete, and if the time permits or there, then only I will chip in. Otherwise, we'll go
Right,
ahead
sir.
with the
Right.
as per the what we decided. No change in the major planning.
Right,
Yeah?
sir.
Good
Dr.
evening.
Anish has joined, sir. Dr. Anish is heading critical care at Max Gurgaon.
Good evening, sir.
Yeah, good evening. Good evening.
Good evening, Dr. Sapra.
अरे हर्षित
Sir.
there.
Hi, how are you?
सब आ गए, thank God. So we are already live, sir.
To
Dr.
start
Anish
with,
has joined, sir. Dr. Anish is heading critical care at Max Gurgaon. ये भी
good evening, sir.
साउंड बंद कर दो धवल.
Good evening, sir.
Hi, Dr. Anish.
Hi, sir. Good evening, sir. Nice to meet you, sir.
Same here.
Good evening, Dr. Shalini.
Good evening. I'm not a member in the panel. I don't know how.
Welcome, please. It's our society.
You are always our member,
Yes.
Shalini.
So, sir, we'll play a small video from World Stroke Organization. Before that, we'll pay homage to Dr. Chaitanya's father. He passed away yesterday. It was little unexpected. Then we'll start, sir. Dhaval,
Yes, sir.
we are starting.
Okay, sir. We can
Okay.
start, sir.
Yeah. Good evening, everyone. Welcome to the webinar to mark the World Stroke Day, 29th October 2025. On behalf of SNCC, Dr. Prashant, Dr. Sapra, Dr. Sapil Zirpe, our chairpersons, and me, Dr. Yash Javeri, I welcome you all to the webinar. I'm thankful to the faculty who have joined us, Dr. Angel, Dr. Anish, and Dr. Ankur Khandelwal, and welcome Dr. Sharin Nair also. To start the proceedings, we'll try to sort out the things first. I'm very sad to inform you all that Dr. Chaitanya's father, our core member, who was the organizing secretary for SNCC annual conference also, he passed away yesterday. He was a pediatric anesthetist, Dr. Ravindra Kumar. It was a sudden demise. Our deep condolences to the family, and we'll have a silence for a minute and we'll pray for the departed soul. Thank you all. I'll hand over to our respected chairpersons. I'll just do a customary introduction, although all of the chairpersons are stalwart in our field. Dr. Kapil Zirpe sir. Dr. Kapil Zirpe sir is a very senior intensivist, past president of ISCCM, and he is at Ruby Hall Clinic. Dr. Harsh Sapra sir, welcome Zirpe sir. Dr. Harsh Sapra sir. Dr. Harsh Sapra is heading neuroanesthesia and neurocritical care at Medanta Gurgaon, and he has been in forefront of neurocritical care. And Dr. Sapra, Dr. Zirpe have been the people before because of which SNCC is here. And Dr. Prashant Kumar, he will be joining in few minutes. Dr. Prashant Kumar is my senior, and he is professor of anesthesia at PGIMS Rohtak. He is the present president of SNCC. Over to the chairperson, sir.
Good evening. All of us know that we are here to just observe the World Stroke Day. And every year, 29th October, we follow the World Stroke Day. And this year's theme is every minute matters. Every minute counts. We need to pick up those early signs in a stroke and reach to the nearby stroke radio hospital as early as possible. That's what the theme. With this short introduction, I request Harsh to say a few things about today's webinar. And I think, yes, you just continue with the introduction and the continuity of the program. Yeah.
Yes.
Thank you. Thank you. Harsh.
Yes, sir. So I welcome everybody to this World Stroke Day seminar. And as what we have been doing in the past, we have been focusing on days through the society, days of relevance. And we sort of try to do some academic activities on specific days. And obviously, Stroke Day is very, very important to us, especially when the incidence of stroke is increasing in the country, and so are the avenues and treatments, and in the recent last few years there have been a little changes in the guidelines as well, and winter's approaching and the stroke cases anyways going up, so it is very important for us to talk about it now. With that small summary, I would request Dr. Zaveri to introduce our first speaker.
Thank you, sir. We'll play the World Stroke Organization video first. Dhaval, can you please play the video?
Enam bulan yang lalu, saya diserang stroke.
Y me di cuenta que mi voz sonaba extraña. Luego perdí la conciencia. Por lo que me han contado, se me organizó el lado derecho.
My husband noticed that I had extreme facial droop on the left side of my face.
Por lo que llegó una camarera que al darse cuenta que no respondía, llamó a la ambulancia.
He immediately called for ski patrol, who then called 911.
Terima kasih telah mendapat rawatan trombotomi ini dan dia telah menyelamatkan nyawa saya.
Trombolysis, mi vida sería una muy distinta. No me habría recuperado, podría estar contrado y tal vez hubiese muerto.
My name is Esma Daniel. I'm a stroke survivor.
Hola, me llamo Francisco Daniel y soy sobreviviente de una CD isquémica.
My name is Lara Kaufman. I am a stroke survivor.
Thank you, Dhaval. We'll begin with the first presentation for the day. I'll be delivering the first presentation will be Are the slides visible? Full screen?
Yes, they are.
Yes, sir.
Okay. So the first presentation will be to sensitize us all about World Stroke Day, what is the significance of World Stroke Day and why we are celebrating this day. We, on behalf of Society of Neurocritical Care and representing many other societies, we are ambassadors for stroke care in our country. Especially if we say Dr. Zirpe has taken a big responsibility and which is recognized worldwide also. Likely, all of us have been stalwarts in our field and working towards improvement of stroke patients by every passing day. World Stroke Day 2025. The aim of World Stroke Day is to bring stroke advocacy and stroke awareness together to drive action on stroke. We want to bring stroke to the front burner of our healthcare policy and to sensitize people about seriousness and urgency of stroke care. The focus for World Stroke Day 2025 is to put spotlight on the life-saving importance of spotting the signs of stroke. The first step towards treating any disease is spotting and recognizing the symptoms of disease. Stroke symptoms, we all understand, can be very, very diverse. They can be missed easily. That is why it is very important not only to sensitize healthcare providers, but also to sensitize the common man on the street about recognition of stroke symptoms. The theme this year is building on the every minute counts theme. So we'll try to understand why every minute, why every second counts in stroke care. We are going to share two clear calls to action. The first one is to understand the science of stroke and to be ready to act fast, which is the clinical management of stroke. The other part of World Stroke Day 2025 campaign is to sign the Global Stroke Action Letter of Support and to add our voice to best of our capacity. We might be representing a small society, we might be representing a big society, we might be representing a hospital, or in our individual capacity. We must raise our voice for recognizing stroke as a big factor for morbidity and mortality. And this will be a call out to our stakeholders, to our governments to commit for putting strokes on front burner of healthcare priorities. So stroke action now is the second goal of World Stroke Day. How this World Stroke Day began? The concept of World Stroke Day was first introduced in 2004, not very late. And the concept was first organized by World Stroke Organization. World Stroke Organization was formed by merging two global bodies, International Stroke Society and World Stroke Federation. The aim was to unite international efforts to raise awareness about stroke prevention, treatment, and post-stroke care. And a lot has happened on the front of stroke care, sensitizing stroke care, sensitizing people and healthcare authorities on stroke care worldwide. And there has been some momentum in India also for last 4 or 5 years, but still we have a long way to go. Why October 29? The date October 29 was chosen by WSO to dedicate a global day of action and education about stroke. Although as neurocritical care physicians, we almost daily are treating stroke, we are talking about stroke. But if we have a single dedicated day, our efforts are added and our voices are heard better worldwide. So this will highlight the global burden of the stroke and the need for urgent coordinated efforts to reduce its impact. So we must start talking about stroke, start talking about stroke care in our hospitals, dedicated pathways for stroke care, and NABH, JCI, everyone has been recognizing stroke as a priority, and stroke centers has been reaccredited by these agencies worldwide, and they are now trying to categorize according to the level of stroke care provided at various stroke centers. The theme, as we already discussed, every minute counts. So we must know the science of strokes and be ready to act fast. A stitch in time saves 9. An action in minutes can save a lifetime. It can avoid a lot of morbidity. It can avoid a lot of morbidity. It can avoid a paralysis. It can avoid aphasia for a patient. And it can be a major moral booster where the outcomes are drastically changed by thrombectomy or by thrombolysis by the stroke team. The clock is always ticking in the ED. Every second counts. Time is minute, time is life. We all know that. While we care for stroke, every minute during a stroke management, 1.9 million neurons die. So we all understand that early intervention will have better outcomes and lost time is never found again. So we must act fast in recognizing as well as treating stroke at our centers. We all understand stroke has a major incidence and prevalence. 1 in 4 adults will have a stroke in their lifetime. So if we take 4 of us, at least one amongst us can have stroke in our lifetime. 5 million deaths and another 5 million disabilities each year. And these numbers are big, astronomical. Whatever happens in India happens big. We are stroke capital of the world because of non-communicable diseases, diabetes, hypertension, thromboembolic stroke. So the incidence is huge in India, and India accounts for more than 1.5 million cases annually. Numbers speak louder than words, but prevention is worth a pound of cure. So we must try to sensitize to best our capacities to the stakeholders for treating, for bringing up the pathways to sensitize people and sensitize the healthcare authorities to bring stroke to the forefront. The burden is heavy, but the awareness is light. Awareness amongst common population is scant. Even physicians or healthcare providers in the community, they have a very poor understanding of stroke, and some centers still who are not treating stroke very scientifically, they also lack proper understanding of stroke. So we as ambassadors for neurocritical care and for stroke care, it is our responsibility to take the stroke care pathways to the places where the knowledge is still scant. The incidence of stroke in India is 105 to 152 per 100,000 population. This is a leading cause of disability, we all understand, rising hypertension, diabetes, atrial fibrillation, and many other causes add to the risk. And I'll again re-emphasize 1 in 4 adults face lifetime stroke risk. So the risk is real for all of us. When the brain runs against time, whenever there is ischemic stroke, the penumbra, reinfarction, infarction, reperfusion saves tissue at risk. We all understand this. A moment of delay may cost a lifetime of ability. The clock is ticking every second. So rapid recognition can salvage penumbra. It can avoid secondary brain injury. It can avoid rebleed in a hemorrhagic stroke. So fast recognition, urgent imaging, urgent reperfusion where indicated, and good post-stroke ICU care is must, and it must be scientifically done in an evidence-based manner with a proper checklist. We must make haste while the brain still can be saved. Once the damage is done, we have nothing to gain and we cannot do any drastic clinical change. So we always talk about the mnemonic fast and be fast. Fast is about clinical recognition, face, one side droops, uneven smile. Now with advent of teleradiology and AI, there are apps where the patient or the clinician healthcare provider can recognize the symptoms. There are apps where you can put your photo, and whenever there is asymmetry, you can look in the app and that will tell you that, okay, this could be stroke. Arm, can't raise both arms, one arm is drifting down. Speech, slurred speech, confused speech, hard to understand. S is for T is for time. Call emergency services now. So we should not be waiting for more signs. If we have 3 of these signs, we must understand the probability of stroke is big and we must call the emergency services. And 2 more additions have been done in this. And these 2 common early clues must be understood and must be recognized by the emergency physicians or the frontline healthcare providers that these also could be signs of stroke. B is for balance, sudden trouble in walking, dizziness, loss of coordination. E is for eyes, sudden blurring or vision or lost vision in one or both eyes. These also could be signs of stroke. So now we talk about be fast. There is a minute-to-minute action plan. Minute 0 to 1, we call the emergency services. Whichever country you are in, we call 112 or whatever number is prevalent in your areas. We note time symptoms started or last known well, minute 1 to T2. Keep the person sitting or lying safely, clear the hazards. Do not give food, drink, or medication. The healthcare provider must evaluate urgently, and they must evaluate him first before we start giving. And this is a common myth and common practice at most of the places. They start feeding or putting water in the mouth of a person who has stroke. So we must avoid this. And minute 2 to 3, if you can gather medication list, allergies, and IDs for paramedics, we must gather more clinical information. we must watch for worsening or new symptoms like confusion or severe headache. So this is minute-to-minute plan which must be propagated in our societies, in our EDs, amongst our EMTs and ambulance staff. These are the timelines which most of us are aware. I will not go into details, and the speakers after me will be discussing these things in greater detail. Hope springs eternal. So apart from recognition, early thrombolysis, early thrombectomy, stroke team, post-stroke care in the ICU, we must look at early rehabilitation for better functional recovery. This is not done at par to the global standards in many of the ICUs, but we are improving on every front. And rehabilitation for the stroke patient starts at the time of diagnosis. So we must act fast for rehabilitation also. It must be multidisciplinary physiotherapists, occupational therapists, speech therapists, dysphagia specialists, psychologists. So every cloud has a silver lining, and neuroplasticity is the brain's miracle. We must look at multidisciplinary rehabilitation on all aspects which affects the life of the patient. Together, we can turn the tide. We must build stroke-ready centers across the nation, and the first talk by Dr. Anish will be focusing on what it takes to be a stroke-ready center. We must educate public, and we must train first responders, including our colleagues in peripheries or the frontline healthcare providers in the emergency or in the ambulance. We must advocate for policy support and rehab infrastructure. And a lot has been happening, and the Ministry of Health has recognized stroke as a major challenge in coming years, and the policy has been accordingly modified. The genesis of stroke care programs briefly in India, early initiatives 2000 to 2010, there were tertiary care models. Few of the centers across country were actually giving good protocolized care for stroke, but this has propagated to more and more hospitals now. More and more hospitals are having stroke centers, stroke ICU in the gamut of things. And non-communicable disease and stroke framework has been integrated by Ministry of Health in non-communicable disease network. Stroke units have been established in major private as well as government hospitals. And there is stroke networking in government hospitals also. And there is spoke and hub pattern functioning in many of the states now. There were initial hub and spoke pilot projects which started somewhere early in 2004, and now we are seeing more and more of such projects. There was a AIMS-led National Stroke Network 2018 till present. There are various state registries, Tamil Nadu, Kerala, Maharashtra, but most states should follow these state registries for stroke. TPA has been included in many public hospitals, and the third-party healthcare insurance is now paying for TPA also. Integration with EMS and tele-stroke programs have happened in many of the hospitals, but still it's a long way to go. So emergency medical services, the pre-hospital care must improve, and tele-stroke programs could be beneficial for improving the pre-hospital care of the stroke patient. We must understand the chain is only as strong as its weakest link. There are many challenges, there are many opportunities. The biggest challenge is delayed presentation and low public awareness. However, the industry, the healthcare providers, especially the private players, have been trying to increase awareness amongst the public, and there have been hoardings in many cities, even smaller cities. There have been posters on the autos which talk about the symptoms of stroke. Shortage of neurologists and trained ICU staff is another challenge, but we must train our emergency physicians, our intensivists, our anesthetists, or acute care health providers to recognize stroke and treat in a multidisciplinary fashion. The stroke team depends on the level of healthcare facility you are. At times, you might have to include a neurologist on phone. You might have to take a teleradiology help. So the team varies from point to point, and you have to be contextual. Limited rehabilitation and follow-up infrastructure still remains a challenge. Rehabilitation facilities are not yet up to the mark and not freely available across the country. Opportunities are many. Training intensivists, anesthetists, emergency physicians, pre-hospital clinicians and nurses and EMTs. AI triage tools are already there, and point of care emerging has been appearing and now has been used commercially at many of the hospitals. So we must bridge the gap from policy to bedside. The road ahead, stroke ready India 2030, or it might take some more years. The vision is to have a national stroke care grid. Goals, universal stroke ready centers, stroke registry, nationwide tele-stroke coverage. Partnerships, various agencies, ICMR, ISCCM, ISNAC, Neurocritical Society of India, Society of Neurocritical Care, which is represented by us, WHO, and all other stakeholders should be partnering in this noble cause. So, this is a call to action. We must act together to save the brain of a nation. The strength of a system lies in its preparedness. So we must be ready, we must be prepared to recognize stroke and to treat stroke once they have presented to our healthcare facility. Again, to emphasize, every minute counts. Your action today could change a life tomorrow. Thank you, chairpersons. I will hand over the stage to the chairpersons.
Yeah, thank you, Yash.
Thank you, sir.
I think you can go ahead with the next speaker, introduce him, and he can start.
Yeah. Thank you, sir. Thank you, Dr. Sapra. So the next speaker is Dr. Anish Gupta. Dr. Anish Gupta is heading critical care at Max Gurugram. Dr. Anish will be talking about what it takes to be a stroke ready center. We are eager to listen from Dr. Anish. Over to you.
Thank you so much, sir. At the outset, I would like to thank Yash sir and the entire organizing team, SNCC, for giving me this opportunity to present today. Are my slides visible?
Yes, visible. Now they have disappeared.
Yeah, is it visible?
Yeah, full screen. Yes.
Okay. So I'll be talking about what it takes to be a stroke ready center. So yes, sir has already discussed this, but I'll just go through it for kind of completion and to give a brief introduction also. So India accounts for nearly 10% of the global stroke cases worldwide, which is a very huge number. The incidence and prevalence rates of stroke in India have actually increased from those in developing countries. So we actually changed from communicable diseases prevalent country to more of a lifestyle disease prevalent country now. From 1990 till now 2021, we've seen a 51% rise in the new cases of stroke. The cumulative incidence is 105 to 152 per 100,000 people per year, and the overall prevalence in 2021 was about 9.4 million cases, which about 6 years before that was about 4.6, 4.7. So it's nearly doubled over a period of 5 years. Now, stroke is the fourth leading cause of death and the fifth leading cause of disability in India. So the incidence, prevalence, the overall mortality, disability is very high because of stroke, even in our country today. And that's because of a lot of lifestyle disorders that have been there. Even media couldn't neglect this, and we see that stroke causes more deaths in our country than malaria, TB, and HIV combined. So, like I said, we are seeing a very paradigm shift from communicable disease predominant to a lifestyle disease predominant country now. As a result, early diagnosis and treatment will be very crucial in these patients. Time is brain. In heart attack and myocardial infarction, we always talk about time is muscle, but now time is brain in stroke, and that's been there for quite some time. Every minute counts, which is also the theme for World Stroke Day today. And with every minute delay in treatment, about 1.9 million neurons are lost. I think this is where a stroke ready center will come, because it will help bridge the gap between the community and provide comprehensive stroke care to all the patients. A stroke ready hospital will also be the differentiating factor between life and death, or the game changer that we may see, and will help in full recovery and prevent long-term disability. So what is a stroke ready hospital or a stroke ready center? So it is basically a hospital which is equipped to rapidly diagnose, stabilize, and initiate treatment for acute stroke. Now, these facilities are designed to provide specialized, fast, effective care for the stroke patients, and this will help us save lives and improve the outcomes. And as a result, this will help bridge the gap between the community and provide comprehensive stroke care. Now, a typical patient of stroke reaching a SRC hospital. So, how is the treatment protocol or the management process? So, it's initial rapid assessment and diagnosis. Then the stroke protocols get activated. There's a code stroke which will get activated, and there'll be protocols which will be in place. There'll be a multidisciplinary team approach to these patients and post-stroke care and rehabilitation. So it's like an end-to-end care. It's not only the acute care that we're talking about. The patient comes in, if he's in the window period, we thrombolize, or if there's a large vessel occlusion, we go for a thrombectomy. But we are also talking about the initial management, stabilization, discharge of the patient, rehabilitation, occupational therapy, physiotherapy, dysphagia therapy, all of these. So that's what a stroke ready center is supposed to do. It's not only the initial part of treatment. Now, the key components of a stroke ready center. So you have an emergency care, you have to have imaging facilities, stroke team, laboratory and diagnostic support, thrombolytic capability, ICU and monitoring services, ambulance and transport services, pharmacy support, and post-stroke care. All these components together and working in sync will help us establish a good stroke ready center or a hospital. So I'm just going to discuss one by one, just in short, each of the components. So from emergency care, there has to be a 24/7 ER department, and there has to be a code stroke which can be activated also throughout the day and night. The staff should be trained on fast and be fast. We follow some timelines when we have a patient of stroke or a suspected stroke who comes to us in the ER. So one of the timelines is a door to a CT time, which should be less than 20 minutes, including the reporting. Apart from that, as per AHA, ASA, there's a door to needle time of less than 60 minutes. So once the patient arrives, which is taken as time 0 to the ED, after that, the patient should be evaluated within 10 minutes by the physician, and you should have some focused examination, NIHS scoring, get the stroke team notified, go for an urgent imaging. CT scan is what is recommended. If there are facilities for MRI, sometimes the diffusion imaging can be done if time permits, but usually it's just a CT scan that is required. Interpretation of the scanning should be done within 20-minute timeline, and we have to try and start the thrombolytic therapy within 60 minutes if it is indicated. So imaging facilities, in case a post-stroke is announced, then we should have facilities to do the CT scan as soon as possible. So first is the availability, which should be there 24/7. And secondly, even if there's a patient in the scan who's undergoing a scan, but a code stroke is announced, then we may have to get that patient out and put the patient with a suspected stroke so that we can identify it as soon as possible. Optional imaging facilities like a CT angio or CT perfusion can be performed. MRI with limited MRI scans can be done in some patients, and the reporting should be available within 20 minutes. Now the stroke team. This is one of the most important aspects because the stroke team comprises of all the components. So the doctor, which includes the ER physician, a neurologist, a neuro interventionist, a neurosurgeon, the ICU physician, all of these form the part of the stroke team. Apart from that, nurses and paramedical support, which is required, who should be trained in basic neurology, basic identification of stroke cases. That's important. Pharmacy support, availability of all essential medicines, including RTPA, is important. Apart from that, from rehab perspective, a neuropsychologist, physiotherapist, social worker, occupational therapist, a speech therapist, and a dietitian. So again, we are talking about right from the patient entry till the patient goes back home and is rehabilitated. These all components are a part of the stroke team. Lab and diagnostics, again, laboratory facilities should be available round the clock with all the possible tests. Today, I think most of the big corporates definitely have these services available, and it's quite easy to get. And with now point of care testing, I think probably smaller centers also are able to get the test done at a faster pace. Capability for thrombolysis. So it's not that thrombolysis should be done only during the day hours, but thrombolysis patient should be possible to do thrombolysis, thrombolize, sorry, even at night, whether it's with alteplase or with tenecteplase. So the neurologist or a neurosurgeon should be available so that thrombolysis can be carried out. Therapy should be driven by protocols as per guidelines, as per recommendations, and we should try and maintain the timelines of a door to needle time of less than 60 minutes, because time is brain and that's what's going to help us save the neurons. In case there's any indication for of large vessel occlusion, and if you to think about a mechanical thrombectomy, then facilities of cath lab with a intervention radiologist or a neurointensivist interventionist, sorry, is required so that thrombectomy can be carried out in a timely manner. Post thrombolysis, the patients usually will be coming to the ICU and monitoring have to be done, which depending upon what is done. If it's just thrombolysis, if it's after IV alteplase, then we monitor for GCS and vitals every 15 minutes for 2 hours, and then every 30 minutes for 4 hours, and then every hour for the next 16 hours. And that is how it goes. The main point is you have to watch for any neuro deterioration in these patients, because these patients can have an IC bleed that may happen in them because of the thrombolysis. So it's very important to be very vigilant for this. Also look for signs and symptoms of raised ICP in these patients. So monitoring ICU plays a very important role post thrombolysis, and they should be vigilant, and the doctors on duty should be vigilant enough to identify any change in the neurological status of the patient. Support by pharmacy, ambulance, and any transport facilities. So always have BLS, ACLS ambulances, because sometimes you may get a call where the patient is at home and is having some facial droop or is having some weakness of any limb, and it could be suggestive of stroke. So the ambulance and the paramedical staff in the ambulance should be trained in recognition of stroke. Protocols for transfer inter-hospital and intra-hospital should also be defined. The pharmacy should be stocked with all essential medicines, including antiplatelets, statins, RTPA, reversal agents for them, and should maintain a strict cold chain so that the efficacy is preserved. Post-stroke care, so initial diagnosis and treatment, and then, like I said, we'll go for either home care, which is stage 3, or outpatient care, or maybe after the discharge of the patient, if depending upon the recovery level. So out here, we may need support from physiotherapy, occupational therapy. You have now robotic physiotherapy, which is there in available in hospitals. So patients may have to be called back for those kind of things to try and make them as rehabilitated as possible so that they can get back to their work, or you have to look for alternatives. A psychologist will also play a very important role in these patients, because there's a lot of post-traumatic stress that comes in these patients, and that also has to be looked at and taken care of. So what are the advantages of a stroke ready center? So these were all the components. Now the advantages is because it's a multidisciplinary team approach that is happening, and because there will be protocols and guidelines and timelines that are there, the time to treatment will be shorter and it will be faster. As a result, this will help improve the patient outcome. Plus, the patients will get the benefit of getting access to specialized care, more comprehensive care, more protocolized care, and this will eventually reduce the mortality and improve the morbidity also, reduce the morbidity also of the patients. Apart from that, there will be quality indicators and metrics, so as we can always assess ourselves and see where there are gaps, where we can improve, where we can make changes so as to improve the overall outcomes. So we can maintain a stroke registry, which could be at the center, and then that can get integrated into state and national registries. You do audits of the door to CT time, door to needle time, within how much time the physician is seeing the patient, what is the timeline to get the medicines, the CT scan reporting. All these timelines can be actually assessed and they can be benchmarked, and we can also see whether the changes can be made to improve it further, plus monthly reviews and audits that are conducted. Even if you go by AHA guidelines, there is one of the points is of establishment of data repositories, and there should be participation in a stroke data repository to promote consistent adherence to the guidelines, and this will help improve the quality and patient outcome overall. So what do the guidelines say? So we have the AHA guideline, which is basically for acute ischemic stroke, and it's a 2019 update to the 2018 guidelines. So there are some of the points that I'm going to discuss. I won't go into the details. These are available on the net, but just to give you an idea about how a stroke center or hospital should be. So, certification of stroke centers by an independent external body. So, this is from, since it's a US based guideline, they also say that the stroke center should be certified by an independent external body. Now, the important part is data support the development of stroke centers to improve patient care and outcomes. But there's a difference in the stroke quality of care associated with difference in the certifying organization. So this is actually quite surprising that different organizations in US also, which are certifying a stroke center, they've actually seen that the use of Altiplace is higher in some certified organizations as compared to the other ones. And the door to needle times are not met, especially in the ones which the certifying centers, certifying authorities which are state run. So this comes as a surprise, but this is what has been mentioned in the guideline, and probably they are also trying to rectify it. So this is one important point. Apart from that, about stroke teams, there should be an organized protocol for the emergency evaluation of patients with suspected stroke. There should be a designated acute stroke team, which includes physicians, nurses, laboratory and radiology personnel. And there should be quality improvement initiatives, which involves multiple components. It could be education in the ED of the doctors, of the nurses, the multidisciplinary team involvement, and they should be assessed for neurological expertise and how to safely use IV fibrinolytic therapy. It is also recommended that the stroke systems of care be developed so that fibrinolytic eligible patients and mechanical thrombectomy eligible patients receive treatment in the fastest achievable onset to treatment time, and also establish and monitor target time goals from ED door to the treatment IV fibrinolysis, because this will only help enhance the system performance. Apart from that, when we talk about the stroke system care quality improvement process, then healthcare institutions should organize multidisciplinary quality improvement committees to review and monitor the stroke quality benchmarks, indicators, and evidence-based practices. Apart from that, the stroke outcome measures should be adjusted for baseline severity, and there should be a continuous quality improvement process. All hospitals which care for stroke patients should develop, adopt, and adhere to protocols that reflect current guidelines and as established by national and international professional organizations. For transport, whether it's intra-hospital transport or inter-hospital transport, there should be hands-off and transfer protocols in place to ensure safe and efficient patient care as well as transport during these facilities are availed. For mechanical thrombectomy, there should be rapid access to cerebral angiography. There should be qualified neurointerventionalists and a comprehensive peri-procedural care team should be available. If a primary stroke center has facilities to provide initial emergency care and IV Altiplace, they should also try to select patients for transfer for mechanical thrombectomy and reduce the time to mechanical thrombectomy. Apart from this, we need support from government agencies and third-party payers to develop and implement the reimbursement schedules in US. This is for this is a US guidelines from that aspect. But we need support for overall developing more stroke-ready centers so that the facilities can be available at even tier 2 or tier 3 cities to patients. So what are the guidelines for stroke centers? So you have the American Heart Association, American Stroke Association 2023 guidelines and the WHO 2020 guidelines. So they suggest that you should establish tiered systems, which is a stroke ready center SRC, a primary stroke center PSC, and a comprehensive stroke center CSC. They have some recommendations where you ensure a 24/7 CT available, thrombolysis to be done within 60 minutes, maintain data registries, and continue staff training. Then we have the Indian Stroke Association guidelines, which basically say there should be a CT scan access, a trained physician, stocks for RTPA, and there should be a referral linkage system that is developed between hospitals, between smaller setups and larger setups, or and even small like a PHC to a CHC, and then to even government setups for that matter. And there should be reporting in regular audits. Common to both is that the CT reporting time has to be within 20 to 25 minutes. Window for thrombolysis is less than 4.5 hours, and there's a door to needle time of less than 60 minutes. Apart from that, continuous audits and training should be done for all the staff. So the minimum requirements as such for an SRC certification is a 24/7 ER with a code stroke system in place, availability of CT scan and other radiological facilities, availability of RTPA and tenector place, because tenector place is also used nowadays for thrombolizing stroke patients, trained physicians and nurses in stroke, as well as a little bit of neurology to make sure they can identify the patients of stroke. Post thrombolysis, availability of ICU bed and a registry to be maintained and a referral protocol. Now, this is done by the ASA and AHA, where they have the levels of stroke centers. So you have a basic care hospital at the bottom of the pyramid, where assessment, identification, stabilization, and transfer is basically done. Then you have a acute stroke ready hospital, which has the facility to give IV TPA. There'll be a CT scan facility and some acute stroke expertise. Telestroke facilities or teleradiology facilities may be available or may not be available at these centers. Then you have a primary stroke center, which consists of a dedicated stroke unit with a coordinator and a stroke service, a stroke system, and that will help in continuation of patient care. While in a comprehensive stroke center, you have facilities for basically thrombectomy, a neurosurgeon, neuroendovascular person, a full spectrum of hemorrhagic stroke care will be available at this place. In 2018, they've introduced the thrombectomy capable stroke center in between the primary stroke center and a comprehensive stroke center. So this is how it is. You have the acute stroke ready hospital, then you have the primary stroke center, then you have a thrombectomy capable stroke center and a comprehensive stroke center. So thrombolysis can be conducted in all, but for thrombectomy, you may have to go to the last two, which is the thrombectomy capable stroke center or the comprehensive stroke center. Now in India, so this was about what the guidelines say and what are the types of stroke ready hospitals or centers that can be there and what are the key components. Now, whether there's an accreditation available. Yes, there's an accreditation available. So in India, we have NABH, which is there for hospitals, but now there are also certification standards for stroke center. And I think Kapil sir has just posted yesterday only that Ruby Hall got the stroke center certification from NABH and would like to congratulate sir for that. Apart from that, you have JCI as well as AHA, ASA, which has stroke certification. So there are different types of certification programs, like you have the primary stroke center as well as the advanced stroke center program by the NABH. And by the JCI, you have acute stroke ready hospital, PSC, thrombectomy capable stroke center, and the comprehensive stroke center. So there are guidelines on how to apply for this and what are the requisites, and it can be done for a lot of setups in India for that matter, and probably it will get a lot of standardization. So I've just put in a slide on NABH eligibility criteria for acute stroke ready hospital. So they have these components, which is that the stroke care facility should be functional for at least 6 months. The NABH standard should be implemented, fulfilled. 24/7 availability of designated stroke team and a neurologist. The center should have served a minimum of 120 stroke patients in a year or at least 10 per month on an average, and perform minimum 6 endovascular thrombectomies and 12 thrombolysis annually. Apart from that, availability of neurointerventionists and designated neuro ICU beds. Advanced diagnostics should be available. Facilities for carotid Doppler ultrasound, in-house IV thrombolytic capability, designated stroke certified nurses and coordinators, documentation of stroke triage, diagnosis and emergency protocols, a telemedicine policy in place, and mechanism to evaluate and report key performance indicators. Apart from this, I think regular drills for training education, conduction of CMEs and workshops, and nursing certified programs will help in improving the quality of a stroke center. And community outreach is also very important. Apart from just making the hospital ready, we need to make the community ready. So create a lot of campaigns should be conducted to create awareness on FAST and BFAST. Public education and screening camps, if possible, should be done, and collaboration with primary healthcare centers. That's also an important aspect, because probably in tier 2, tier 3, they'll be the ones who will be referring the patients. So if you're able to achieve a referral and a timeline of less than 4.5 hours, you can actually think about thrombolizing these patients. future directions, I think integration of the stroke about what is the actual burden of stroke in our country, and also about where the gaps are and how we can rectify those gaps and improve our delivery of treatment to these patients. Today, AI is coming up in a big way. It's already come up in a big way, and we can always use AI for assistance, for right from reporting to analyzing data, and that may actually help us in understanding how to improve. Apart from that, a 24/7 stroke network expansion is what would probably give a better outcome. I would like to thank you for this, and we need a complex mix of policy, guidelines, practices, standards, rules, regulations, and compliance to make sure that we are able to reduce the burden of stroke in our country. Thank you so much.
Thank you, Dr. Anish. Over to the chairperson, Dr. Sapra, Dr. Zirpe, Dr. Prashant. Comments from you?
I think it's been very nicely concised about a stroke-ready unit, and very well differentiated as to comprehensive stroke units and stroke units where intervention facilities are there. But the only thing is, although it appears good in guidelines, but sensitization needs to be done at various hospital levels, because lot of the times the stroke patients, even if they reach the hospital, arrive to the facility where the facilities are available when no intervention can be done, or sometimes you've lost the boot. So I think we need to spread more awareness, but nonetheless a very excellent and concise talk, Dr. Anish.
Thank you so much, sir.
Prashant, you want to comment anything? Dr. Prashant?
Hi, good evening, everyone. Thank you, everyone, for this webinar. Yash to take the lead as secretary, organizing everything. Dr. Zirfe and Dr. Harsh, our past president and the pillar of the SNCC. Now, this is something very heartening that we all could collect today and hear about the World Stroke Day on the stroke day. And as Dr. Harsh said, it is the time that where we need to have more and more awareness. That is the only thing I see that is required to have a better outcome of a patient, right from the identification to early hospital care and getting some intervention done. Thank you so much, sir.
Yeah, thank you, sir. We move on to the next talk. Dr. Angel is the next speaker. Dr. Angel is faculty at CMC Vellore. She's a neurologist trained thoroughly from MBBS till DM from CMC Vellore. Our keen fields of interest are neuroinfections, and I think I came across her as a faculty while we were discussing about neuromyelidosis. She has a keen interest and she has a lot of original research work on neuromyelidosis, vascular neurology, epilepsy, and immunology. So whenever you have concerns regarding these specialties, she is the person to reach out. Madam will be talking about acute care management of stroke. Over to you, Dr. Angel. And Dr. Angel has been very kind because she has been traveling to Varanasi for her annual neurology conference and she has spared some valuable time from Varanasi. Thank you, Dr. Angel.
Thank you, sir. Good evening, everyone. Thank you for this opportunity, and it's a pleasure to be here in this webinar to present on the acute management of stroke. I'll just share my slide. Is my slide visible?
Yes, please.
Okay. So we'll spend the next 15 to 20 minutes discussing on how to manage a stroke. So if you see, the core concepts with stroke are, once you have an occlusion in a major blood vessel, so your cerebral blood flow actually drops. So at the core, you have your volume drops to about 10 ml. That's the lowest immediately opposite the occlusion. So there the flow will be about 10 ml per 100 grams per meter square. That will be the core of the infarction. And subsequently, around the area, there will be collaterals because your brain has a very good, circular villus, which actually has collateral feeds from other arteries. So there is a concept called penumbra, where there is some flow which is maintained by the other vessels. So the core plus penumbra, if joined together, form a large infarct. So our aim here in acute stroke management, the core might not be salvaged, but at least you should be able to salvage the penumbra. So now coming to large vessel occlusions. So large vessel occlusions, are very important emergencies that you, and as sir and everyone before me had said, time is brain. So most commonly internal carotid artery followed by middle cerebral artery and the vertebrobasilar arteries are the culprits for the large vessel occlusion. And the time to act is within 4 to 6 hours. So what can cause progression of penumbra to infarction? It depends on how long the vessel has been occluded, depends on the status of the collaterals. It depends on how much the penumbral parenchymal tissue oxygen demand. Suppose it's a very slowly progressive occlusion which happened over the years and there is an acute, thrombus which blocks there. The amount of infarct which will happen is actually less as opposed to an acute thrombus which has come from somewhere, either from the heart or from another blood vessel. You will see the volume of penumbra would be higher. And it also depends on how the circle of Willis is different. How each person, there is a variation. Also depends on the artery occluded, ICA versus MCA, ICA versus ACA. If there's an ICA occlusion, you can expect a bigger area which is infarcted. Blood pressures and the tolerance of individuals to the ischemia. So there are two types of patients we see. One are the fast progressors and other are the slow progressors. So if you take the onset time here, the fast progressors will actually skip everything and they will go down immediately, whereas the slow progressors will have a longer time window to act. So how do they behave depends a lot of it on clinical judgment. So this concept of fast versus slow progressors was the basis for an extended window in thrombectomy. All of you know that the stroke care and stroke management pathways have come a long way. So previously it used to be, you have to thrombolize within 3.5 hours, then it became 4.5 hours. Now we can go up to 6 hours in some cases. And now thrombectomies can be done even up to 24 hours. Now there was a recent trial which even says that you can even, if you have perfusion imaging and there's a perfusion diffusion mismatch, you can even proceed for thrombectomy even up to later as to 48 hours. So as you see, the evidence is evolving. But these fast progressors do not give us much time. So they require an early window. So again, as I said, how do you know whether this person is going to be a slow progressor or fast? It depends a lot on the collateral flow. Hyperglycemia, it's one big thing which might again, worsen the progression. Hypertension, onset of early cerebral edema, and a lot of it also depends on how the intrinsic distensibility and the myogenic collaterals are. So now coming to the guidelines. So the last guideline which was published in 2019 actually is the ready to reference. So as we see here, the door to needle time for IV thrombolysis, our goal is actually 60 minutes. And there are a couple of changes which have come. In 2019, tenecteplase can be used instead of alteplase safely. And also the extended window. Initially in 2013 guidelines, it was 3 hours, which was extended to 4.5 hours. So now coming to the first thing, blood pressure management. Most often when the patient comes, it's very important for us to focus on ABC or CAB as we call it. Circulation, very important. But how low or how normal is normal for a blood pressure? So hypotension, hypovolemia should be corrected to maintain the perfusion levels, and early treatment of hypertension is indicated. Okay, so but only if the blood pressure is more than or equal to 220/120. So most often what happens is most patients go to a small clinic or a small place before they reach to a stroke ready center or a comprehensive stroke care center. So the moment they check the blood pressure, in a person with a new onset focal deficit. If they find the BP is around, say, 160 or 170, it's an immediate reaction for them to give a dose of nifedipine or an antihypertensive, which is very bad because already when the large vessel is occluded, on top of that, you give a stat dose of antihypertensive, you're actually cutting short the perfusion even more, the blood pressure drops and the infarct extends. So unless the BP is more than 220 by 120, it's a contraindication for thrombolysis, and it's an indication to give antihypertensive. So what are the antihypertensives do we give? So usually we go by the short-acting ones. That's the labetalol. We give IV 10 to 20 mg slow IV push, and we can do it every 5 minutes, but target should be less than 180 systolic. If you reach the target, stop giving more labetalol and dropping the pressure more, because you need to maintain the cerebral perfusion pressure because in case of large vessel occlusion. Now coming to IV thrombolysis. So IV alteplase should be administered in all eligible patients. Okay, so most often in India, most centers have a CT-based protocol. Patient comes, you activate a stroke code, the ED person sees or the neurologist sees, quickly assess, calculate the NIHSS, rush the patient to a CT. CT does not show a bleed. The first step is to thrombolyze the patient. In our center, CMC Vellore, we use one of the few centers in India which uses an MR-based protocol. So we have only 4 sequences or 4 or 5 sequences which are done when the patient comes, which gives us much more information, which gives us, what is the total air extent of infarction, diffusion flare mismatch. It can tell us where the artery is cut off because we have an MRA also. But majority of the center, CT itself is good enough. So once we know that you run through the checklist that they're eligible for thrombolysis, we go ahead and give IV alteplase at a dose of 0.9 mg per kg. The problem with alteplase is you need to give a 0.1 mg per kg as bolus and the remaining over 60 minutes. And you should ensure that the bolus, the infusion is continued without interruption. Now that the tenecteplase has come, it's just one single stat dose, the bolus 0.25 mg per kg or 0.9 mg per kg, we give it, and that's all. It's just a bolus dose. So in our center, we actually practice tenecteplase more than alteplase. So the best evidence is within 3 hours. And if you see throughout all the recommendations, you can give the doses 3 hours, 3 to 4.5 hours. There's absolute contraindication is somebody who has had a recent or any form of intracranial bleed. It's an absolute contraindication. Or if the patient has got an underlying malignancy, or if you feel that they have a bleeding diathesis, or if they've had taken an anticoagulation, it's an absolute contraindication. So make sure you have the checklist, which can be just ticked off by a nurse or the resident, and you can administer thrombolysis. So moment you thrombolyze, so most often in our center, our practice is we start the thrombolysis in the gantry itself, the MRI or the CT gantry itself, because as said, time is brain. So we do not delay to shift the patient back to a monitored area and then start. The thrombolysis bolus starts off moment you recognize that there is a stroke and the first imaging shows that there is no bleed. Always delay. Another important thing is if you think the patient is in window period, get all the tubes inserted before you shift. That shouldn't waste time, but at the same time, once you thrombolyze, it's unsafe to insert an NG tube or indwelling bladder CBD. Because if it's a massive stroke or a larger stroke, patients can go into retention and you are forced to wait for some time, because if so now, how does the acute ischemic stroke care evolved over the last 2 decades? So if you see 95, the first was the NINES trial, then we have the ASK ECAS-1, then subsequently Atlantis ECAS-2, then we have the big trials, the diffuse selected population, ECAS-3, EPITHET, then we have the DIAS, then came tenecteplase versus alteplase, which proved tenecteplase was equal. Then came all your endovascular trials. That is 2015, big breakthrough, new devices came. And subsequently, we have tenecteplase, not test, wake up, so on and so forth. So all these trials actually have shaped our guidelines throughout. So ECAS-3 is one which actually which made us extend the window from 3 to 4.5 hours. Okay. So in fact, if you actually look at a subgroup, TPA is beneficial even up to 6 hours. But the problem is the numbers were very small. 14% were treated within 3 hours and majority were between 3 to 4.5 hours. So 3 to 4.5 hours is supposed to be the best time window. Why? This is a very simple table for you to remember. If you actually look at the number needed to treat, that is the NNT, and number needed to harm. So most people will say, oh, our time window is between 3 to 4.5 hours. Anyway, patient is just 1 hour or patient is just half an hour from stroke. So we can do it slowly and aram se, but that's not how it works. If you actually see within 0 to 1.5 hours, if you treat, out of your number needed to treat is 3. That means with every third patient, you have a good outcome. Okay. But as you go up, 3 becomes almost 6 by 3 to 4.5 hours. And between 4.5 to 6 hours, it becomes 19. That means the number needed to treat from 3 becomes 19. At the same time, the number needed to harm also comes down. Okay, so that is why not looking at this is more harmful when you go beyond the extended time window period. So we stick to the golden period, that is between 0 to 4.5 hours. Beyond 4.5 hours, you'd probably be causing more harm than good. Then wake-up stroke. Wake-up stroke is another common situation. So in those, if you have a diffusion flare mismatch, you can select those patients for stroke. What do you mean by diffusion and flare mismatch? So in those with unknown onset of stroke, you can do an MR stroke protocol. First do the diffusion sequence and then do the flare sequence. If diffusion is showing a large area, but flare is not showing changes in those large area, you can positively take them for thrombolysis. And low dose versus standard dose alteplase, another big dilemma. This is one enchanted trial where they actually tried giving standard dose, that is 0.9 mg per kg versus a low dose. So why is this? Why did they even think of this low doses? Because you've seen in Asian cohort, there is a lot of bleed. In fact, this was noticed first in the Japanese group where there was very high proportion of bleed with the normal dose itself. So they actually did this trial in their cohort. They found that its low dose is actually not inferior. However, this needs to be validated in the Indian cohorts. Thrombolysis in minor non-disabling stroke. As of now, the recommendation is any patient with a disabling stroke should be offered thrombolysis. So by ways of disabling, you cannot decide saying, oh, patient has got only right hand weakness. Otherwise, sensorium is normal, he's talking, he's walking. But for him, it's a disabling stroke. You should offer thrombolysis. The NIHSS cutoff is actually more than 5. So in mild stroke, the recommendation was revised from 2015 to IV alteplase. So even if the NIHSS is 0 to 4, if the patient has disabling stroke symptoms, please go ahead and offer thrombolysis. And this is another stroke called another trial called PRISMS RCT. In this also, just giving aspirin versus alteplase, it was not statistically significant, but there was some trend towards good functional outcome. Now coming to tenecteplase. So tenecteplase is actually genetically modified TPA with a pharmacological advantage that it can be given as a bolus. Plus, it has got a very smaller, the cost is also low. So we have a lot of trials, Extend 180 NK results. It actually showed that tenecteplase is actually not inferior. And if you pull all the meta-systematic review, it is reasonable to consider 0.25 mg per kg of tenecteplase as a single bolus over IV alteplase. So it helps because it's easy to administer and you don't have to worry about the infusion. And most often alteplase infusion is started, but nobody monitors. It gets cut off or only half drug goes in. So those problems are not there and it's also cheaper. Now coming to mechanical thrombectomy. So in the first trial which actually came out and it was a game changer was in 2015. If you see those patients with medical treatment combined with endovascular treatment, the amount of death and positive outcomes was significantly better. So subsequently, early window endovascular trials, so many of them have came. These are all the landmark trials which actually show that very good outcome. And based on this meta-analysis in 2015 itself, endovascular therapy was approved as an has to be done in those patients patients is large vessel occlusion within 6 hours of symptom onset. So the 6 hours gives us a time. So most often when patient comes, you would have an acute stroke. If you have to inform the DSA team, get the suite ready. Till then, you don't have to wait. You can actually do a bridge thrombolysis so that, they open up the vessel and then you can, the DSA can be mobilized and the thrombectomy can happen. So it has got a very good number to treat. So for every 2 patients you treat, every patient you treat, at least 3 patients have a good outcome. So a mechanical thrombectomy has to be considered in those patients who are actually eligible for it. So there are various instruments which are used. There are stent retrievers, there are aspiration catheters, there are intermediate aspiration catheter. We often, in our center, it's a practice to use stent retrievers, and stent retrievers are known to be very good, and it's a lot of it is technical dependent, and there is a learning curve. But once you ace it, once the institution becomes good in that, it's nothing. I mean, you cannot substitute it with anything else. Later, we have the late window endovascular trials, which is the DAWN and the diffuse. So they use perfusion imaging. So if you have a perfusion mismatch, that means if you have a large area of penumbra, as evidenced in the perfusion scan, you can offer a patient thrombectomy that is within 6 to 16 hours based on DAWN or diffuse. So I'm going to just show you one case we had. Like, this is a 54-year-old gentleman, came since 2 p.m. Time of assessment was 4. Prior to this was ADL independent. So he came with left-sided weakness, hemi-neglect, and he also had so was possibly his NIHSS is very high. So it's likely to be a large vessel occlusion. So we did a stroke protocol, and this is what the scan showed. If you actually see the entire right hemisphere, the diffusion is actually lighting up. It's very patchy. And on the MRA, at the same time in the flare, you're not seeing any changes. So it's an early stroke, and on the MRA, you're not able to see the right IC at all. So we immediately activated the stroke pathway, stroke care pathway. So we actually thrombolized him, and then we took him up for thrombectomy. So this is what we retrieved, the thrombectomy, the huge clot. And this is the post retrieval run, where you actually see the whole vessel is actually the ICA is previously you weren't able to see this thing, and this patient actually had a very uneventful stay. In fact, his deficits improved and he actually went home walking. So that's the beauty of acute stroke management. If this patient would have come late, he would have ended up with an entire hemispheric infarct. He might have gone for a decompressive hemicranectomy, might have remained with a dense weakness, big deficit and a burden. So just thrombolysis and thrombectomy actually gave back the patient So we all know ICH, it's not only ischemic stroke, time is brain, ICH also, time is brain. You have a big hematoma. So the hematoma expansion is highest in the first 6 to 8 hours. So our aim is actually to monitor the patient slowly. And the single most important thing that will cause hematoma expansion is the blood pressure. So the blood pressure has to be lowered within the first hour. That is the norm. Okay. And suppose the hematoma expands despite all your therapy, we can either do a hematoma evacuation or a decompression, and parallelly start osmotic therapy, neuroprotection to take care of both the primary injury and the secondary injury. So hyperacute ICH is less than 6 hours from symptom onset. Acute ICH is more than 6 hours. So in hyperacute, we are allowed to lower BP to less than 140/90. But in acute ICH, if the systolic BP is less than 220, we can get it down to 140 but over several hours. If systolic is more than 220, get it down to 180, and then beyond lower than 180, you take some more time to get down, because this group suddenly lowering the blood pressure can lead to a opposite mechanism, and they can lead to watershed infarcts. We've had patients where we enthusiastically lowered blood pressures to 120 and 130 abruptly, leading to infarctions as well. So this care bundle is an ICH care bundle, which is not a very well recognized thing in India, which has to be actually brought in. So this ICH care bundle is based on the INTERACT 3 trial, which actually showed excellent benefits. So you have the following goal-directed care bundle, that is rapid correction within 1 hour of the patient stay. So this intensive BP lowering, control the hyperglycemia, maintain body temperature, that is control hyperpyrexia. And if the patient had an anticoagulation associated bleed, you have to reverse the anticoagulation. So in fact, adoption of this as a care bundle itself has made a lot of difference. If you see 14.1 versus 17 compared to usual care, that is a significantly better improvement. Now the world is changing. While when I was doing PG, if I can still recollect when intracranial bleed, hypertensive bleeds come, they'll be admitted and we'll tell them guarded prognosis and control the blood pressure and 3 days physiotherapy discharge. But now we're moving into the era of minimally invasive surgery. Our center is one of the centers which actually aces this technique. So patients who come with significant hematoma volume, that is at least our cutoff is more than 30 ml. We offer minimally, before the entire decompression, the skull is taken off. It's a morbid surgery. Now you make a very small hole, mini craniotomy, go in, evacuate the hematoma either microscopically or endoscopically, and it's shown significant mortality benefits. In fact, patients who have bleed volumes of 60 ml, 70 ml, it's very heartwarming to see them come back walking at the 3rd and 6th month follow-up. And this is a very special cohort, patients with ICH on anticoagulation, because now is the era of NOACs. All patients are put on dabigatran or factor Xa inhibitors. So we have in our center something called as a stroke kit. So moment a stroke code is activated, the stroke kit is carried by the nurses immediately to the ED. So in the stroke kit, we have the thrombolytic drugs as well as we have the factor 4 PCC. That is the reversal 4-factor PCC, which is given as a reversal agent. So if the patient was an anticoagulant, like especially the NOACs, we give the factor 4 PCC and offer support to management as early as possible. And if the patient is actually on vitamin K antagonist, we can give immediately. Vitamin K is used as a reversal agent. We also arrange FFPs. And if the bleed volume is more than 30 ml, the patient is immediately taken up for surgery. And all this actually offers a good mortality and morbidity benefit. So concluding, time is brain. Rapidly recognizing and treatment are critical for optimal outcomes. So accurate stroke subtype diagnosis is also important. So ischemic versus hemorrhagic, the workflow is totally different. So remember, reperfusion therapies have to be done, and it significantly improves survival. And every person who comes, despite the finances, that is one thing which I strongly advocate from my center. So we don't look at the financial ability to direct a patient to thrombectomy. If they need thrombectomy, we actually take them up and later talk about finances. So that is one good thing. Blood pressure, glucose, temperature must be tightly controlled, and have a multidisciplinary stroke unit care, because acute care has to be continued. So as Sir rightly said, that we need to start therapy, physiotherapy, swallowing therapy, everything in the acute phase itself when the patient is shifted to ICU. And early secondary prevention rehabilitation also should begin during the acute admission. So that's my mentor, Professor Sanjit. He's the head of stroke unit in our department. That's my entire neurological sciences with the neurosurgery, neurology at the same window. And thank you.
Thank you, Dr. Angel. Very clear, very comprehensive, and you gave us better pathways to walk upon for stroke care, especially about the intracranial hemorrhage. You made the things very, very crystal clear. Thank you.
Thank you. Thank you, sir.
Move to any comments from the chairperson, sir? Dr. Sapra, Dr. Prashant, Dr. Zirpesar?
Very lucid talk, and it is good that you brought up the issue of MR versus CT as well, because obviously with the MR your intervention improves, especially with the flare and DWI mismatch. So I think that needs tertiary care centers need to pick that nuances as well. And I'm sure interventionists are doing more and more MRs in these subset of patients as well. So very lucid talk, ma'am. Thank you.
Thank you.
We move on to the last talk for the day. I'd like to invite my dear friend Dr. Ankur Khandelwal. Dr. Ankur Khandelwal is Associate Professor, Neuroanesthesia, Neurocritical Care at AIIMS Guwahati. His special interests are neurotrauma and pain, and he is a very passionate singer and dancer, and we must learn those tricks from here. He'll be talking about tale of trials for stroke. Over to you, Dr. Ankur.
Thank you, Dr. Yes, sir, for the kind introduction. And my greetings from Guwahati to everyone, respected chairpersons and all the speakers and all the delegates attending the program. So my talk will be focusing on the trials that have been emerging and have emerged over the past 2 to 3 years. This is not a critical analysis. It's just an overview of what new things have emerged in the field of stroke. So my talk has been made very easy by Dr. Angel and previous speaker. So is the screen visible, sir?
Yes, yes.
Yeah. Okay. So let us begin with acute ischemic stroke. The concept of golden hour IVT, now it has been more and more emphasized. Better the outcome if thrombolysis is done as early as possible, preferably within hour and more so within minutes, like the platinum minutes. So this meta-analysis was published in 2024, which included 7 studies involving almost 78,000 patients, and it compared the outcome of thrombolysis within the golden hour versus thrombolysis outside the golden hour. And what it found was patients who were thrombolized within the golden hour had better 90-day excellent and good functional outcomes with similar rate of conversion to symptomatic intracranial hemorrhage. So it's almost an established fundamentally approved thing that sooner the better. Comparing tenecteplase versus alteplase, lots and lots of data have emerged. In 2023, there came the TRACE2 trial, the original trial in 2024, and the ATTEST2 trial in 2024, comparing the efficacy of tenecteplase versus the alteplase within the patients presenting within 4.5 hours of symptom onset. So by and large, all these trials utilize tenecteplase in the dose of 0.25 milligram per kg, which is a single shot injection. Vis-a-vis alteplase, we know alteplase has to be given a loading dose followed by a infusion dose. And what they found was at 3 months, tenecteplase was non-inferior to alteplase with respect to excellent functional outcome with similar safety profile. So with the advantage of a loading dose and with the advantage of a longer half-life as compared to alteplase, tenecteplase is almost emerging as a thrombolytic agent of choice in acute ischemic stroke. And on a follow-up of 1 year of the 2 trials, they found that the results were similar. Tenecteplase was non-inferior to alteplase at 1 year follow-up results. The next big thing in acute ischemic stroke, initially the 3 hours, then the 4.5 hours, and now the concept of thrombolysis up to 24 hours. So recently the 2 big studies, both published this year in 2025, the HOPE randomized clinical trial with alteplase, and then the CHABLIS-2 randomized clinical trial with tenecteplase in patients presenting with stroke between 4.5 to 24 hours, but with certain criteria that these occlusions should be of large or medium vessel occlusions, and hypoperfused area should be much more than the core infarct area with an average core volume less than 70 ml. If these criteria are met on CT perfusion, then the results have shown that Altiplase, both the studies are from China. The Altiplase found that at 3 months, functional outcome was better when patients were thrombolized between this duration as compared to those who were not thrombolized. And the Chablis 2 trial, the primary outcome was the recanalization rates, where it found that the recanalization rates was much higher, significantly higher in patients who were thrombolized with tenecteplase versus who were given placebo. And this meta-analysis soon published took into account 6 RCTs, and it came with a clear-cut data that if the criteria are well met, then patients can be safely thrombolized within 4.5 to 24 hours without the increased incidence of symptomatic intracranial hemorrhage. So this is a big thing that has come up. What about endovascular thrombectomy for large acute ischemic stroke? So far, the guidelines were focused on endovascular thrombectomy with small to medium size infarcts with a cutoff Alberta score more than 6. But then there were no clear consensus. What about those patients with Alberta score less than 6, that is with large ischemic strokes, whether these patients can undergo endovascular thrombectomies? And then these 4 trials published back to back, Rescue Japan Limit trial, the Angel Aspect trial, the Select 2 trial, and the Tension trial. The 4 trials published in all high impact journals, they took into account aspect scores of 3 to 5, that is large infarct volume, more than 50 ml, and they found that in those patients whom endovascular thrombectomy was considered, they had better functional outcome at 90 days with lower mortality as compared to those in whom EVT was not considered. And a 1-year follow-up of the Select 2 trial and the Tension 2 trial, it came up with the finding that they have a better functional outcome, better quality of life, and overall survival, even if patients are even if thrombectomies is done with large infarct volume with Alberta score 3 to 5. So the role of argatroban in acute ischemic stroke. Argatroban is a short-acting direct thrombin inhibitor. So there was this trial published a year back. This is the ARISE randomized clinical trial where they saw the effect of it in functional outcome in patients who received only Altiplase with 0.9 milligram per kg versus a group of patients who received Altiplase with argatroban. But unfortunately, they did not find a difference in functional outcome, but then there was no harm either. So when argatroban was combined with thrombolysis, they did not find a difference. But then another study published in JAMA Neurology, they found that those patients who could not be thrombolized and then had to be taken on dual antiplatelets. And with dual antiplatelets, if you combine argatroban with a dose of 60 milligram per kg for 2 days, followed by 20 milligram per kg milligram per day for 5 days, they found that patients who were administered argatroban with antiplatelets had a better functional outcome at 3 months. So can the combination of antiplatelet or thrombolytic therapy be considered? Yes, there was a meta-analysis which included 11 studies, and it found that if argatroban is combined with dual antiplatelet drugs, there tends to be better functional outcome as compared to only administering dual antiplatelet drugs. What about blood pressures post endovascular thrombectomies? We know about the pressures, a lot about thrombolysis, pre-thrombolysis, post-thrombolysis, but nothing much was available for patients who were who had undergone endovascular thrombectomies. So again, huge trials in good impact journals, the BP target trial, the Enchanted 2 trial, and the optimal BP trial. The protocol involved more or less all the studies, they involved a protocol of maintaining a systolic blood pressure less than 130, that is intensive control of the blood pressure post thrombectomy in certain group of patients, vis-a-vis a conventional control of blood pressure between 130 to 180. And what they found was patients who had conventional control of blood pressure tend to have better outcomes at 3 months. That is, the recommendations are not favorable for intensive control of blood pressure. And then a meta-analysis which included 4 RCTs, it clearly mentioned that better maintain conventional blood pressure control, say a target between 130 to 180 or 140 to 180, that is good enough. Intensive control might increase the incidence of hypoglycemia and other complications. So what has been new in the field of intracerebral hemorrhage? Minimally invasive surgery in ICH. There came the 2 big trials, the ENRICH trial and the MESSAGE trial, published in 2024, and then a meta-analysis. What they found that a patients comparing craniotomy versus endoscopic evacuation or stereotactic aspiration or say minimally invasive puncture surgery, patients tend to have better neurological outcome at 6 months and reduced mortality at 6 months if you consider minimally invasive surgery in ICH group of patients. However, do remember that there are certain common factors which have been associated with unfavorable outcome with ICH, like advanced age, deep hematoma location, large hematoma volume, low preoperative GCS, craniotomy and intracranial infections. But by and large, if the criteria are well met, minimally invasive surgery patients tend to do better as compared to those who have been evacuated by craniotomy. Anemia in ICH, 2 observational studies, one observational, the other RCTs, they have clearly found that anemia is a big contributor to morbidity and mortality when it comes to evaluating at long term because of the multiple reasons involved in it, the primary being the neuroinflammation, which eventually leads to poor outcomes. So better avoid anemia at all stages of intracranial hemorrhage. Tranexamic acid in intracranial hemorrhage. We have seen the benefits of tranexamic acid in neurotrauma, like traumatic brain injury patients and other sort of injury patients. But then the role of tranexamic acid in spontaneous ICH, there was 3 big trials: the STOP MCU trial, the TIC2 trial, a post hoc analysis, and the intrinsic trial, which was done from India. And what they found that the patients who were administered tranexamic acid did not find a difference in functional outcome, nor with tranexamic acid there was a noticeable reduction in hematoma growth. So what they concluded is that probably there is no role of tranexamic acid once it comes to spontaneous intracranial hemorrhages. Blood pressure control post ICH. Again, one was the RANGE trial published in 2024 in neurology. It was an observational study, and then there was another observational studies. What they found that again, within 6 hours of stroke onset, any patients who has landed up with a blood pressure more than 150 systolic, if you have targeted the blood pressure less than 140 within 60 minutes of presentation, and if you have sustained it for 24 hours, the RANGE trial found that the patients who were targeted less than 140 within 1 hour tend to have lower incidence of hematoma expansion and better functional outcomes. So with spontaneous ICH, do remember that as soon as you receive the patient, if the blood pressure is more than 150 systolic, try to come down to less than 140. That would be good enough. So these are all what had been new in the field of ischemic stroke and intracranial hemorrhages for the past 2 to 3 years. Thank you for your patient and listening.
Thank you, Dr. Ankur. Despite his laptop crashing, we could sustain and survive the crash. Excellent choice of articles, very relevant and very crisp. Thank you. Over to the chairperson, sir.
I think without wasting time, now we'll wind up. But before that, whatever the said and done, we talk a lot about what we are doing in-house, and I still feel more than 10 years or more than decade we are trying, but community has hardly know about the early warning signs. There's hardly any facility, they know about the stroke ready hospital nearby. There are facilities are lacking. Like in between, there was a paper which shows that 1 in 4 Indians are not getting the basic facility for the stroke care. So, as a clinician, as a researcher, as a doctor, we need to give our certain time for the community reach programs, create a lot of awareness, create a continuous awareness throughout the year rather than one day to another day every year. And we need to you need to find out a solution where there will be the easy access available to know which are the stroke ready hospitals nearby that particular patient. I think that should be the our major target. And today's all speakers were excellent and they were very thorough. But again, I'm saying this year's theme itself suggests that we need to reach to the community very aggressively as a part of the community, as a doctor, as a part of the organization. And I request SNCC, ISCCM, and all organizations who are related, like emergency related with the stroke, they should do regular community reach programs. That's what my suggestion. Thank you. Thank you, Yash.
Thank you, sir. Dr. Sapra, Dr. Prashant, sir, final words.
I think very lucid presentations and excellent presentations by all the speakers. As Dr. Zirpe rightly pointed out, that in spite of the advances made in the stroke patients and all the guidelines of improving therapy, the benefit is not being passed on to majority of the patients because of lack of awareness. So my plea to the society would also be to, it's a very good initiative to celebrate these days, but we should pick up 1 or 2 burning issues every year, and we should focus on them and percolate it to the community. It has been percolated enough to ourselves, and a lot of doctors know a lot of things about it, but I think we need to move a step forward and percolate the things to the community where practical things can be taught to them, and the awareness campaign can be driven in various cities through the society on an annual basis rather than on a particular day basis, choosing the burning topics one by one, and stroke being both ischemic and hemorrhagic stroke being one of the topics.
Thank you, sir. Dr. Prashant, final words. And
in fact, before Prashant chip in, I have just came one idea in my mind. We have committees, we have the various sections. Why can't we have the one section on the community reach programs? The entire throughout the year, that committee or those members will think over it, they will plan, they will implement, and they will keep a follow-up how regularly we are doing this committee reach program. So along with all these committees, you can add one committee, and that's what Prashant, we can request the president and secretary to take this idea further.
It's a very nice idea.
Absolutely, sir. I fully agree. And as a society, we'll try to implement what you have just suggested. It's an excellent idea. And we will definitely take it forward. This will take our outreach program as well and reach to the other medical friends in country. And I really thank all the speakers for taking up the session, and especially when it was done on a very short notice with you all, given very less time for your presentations and topics. But I think what you have done is more than the justice what we could have expected from you. And the caliber and your in-depth knowledge, as Dr. Zerpe already said, has benefited all the participants who joined us today. Thank you very much. Thank you everyone. And I also thank Dr. Zerpe and Dr. Harsh who took the leads and steered the sessions. Thank you everyone. My best wishes.
Thank you. Thank you. Good night. Thank you, Dhawal,
Good night. Good
for
night.
the support, Dhawal. Thank you.
For organizing this, Dr. Yash.
Thank you so much, sir.
Thank you. Bye-bye. Have a good